Welcome back to the deep dive. Today we aren't just reading papers. We're simulating a pressure cooker. I'm putting myself in the hot seat specifically. That stiff wooden chair across from a senior examiner at the Gujarat University MD exams. My palms are already sweating.
As they should be. The MD Viva isn't just a test of knowledge, it's a stress test. I'm going to be that intimidating voice across the table. But remember, my goal, and the real examiner's goal, isn't strictly to fail you, it's to see if you're safe. Do you understand the engine of the human body, or have you just memorized the manual?
Right, and the topic on the table is the dreaded long question. It's a monster. Treatment of hypotension causes, classification, and pharmacological management. And just to make it spicy, the prompt specifically asks for details on vasopressors, inotropes, and Levosimendan.
That is a classic 20 marker. And here's the first trap. Most residents, they just dive straight into the drugs. They want to talk about norepinephrine dosages immediately. If you do that, you've already lost.
You've missed the whole foundation.
Exactly. You need to build the house before you decorate it. You must start with definition, physiology, and classification. If you don't frame the problem, you can't solve it.
Okay, right. So let's start with the definition. And honestly, this feels like a trap immediately. If I quote Miller's, I get one set of numbers. If I look at Harrison's, maybe it's different. What does the examiner actually want to hear?
They want precision, but they also want context. If you simply say hypotension is a systolic BP under 90, you are technically correct, but you're clinically naive.
Because a generic number doesn't account for the patient's baseline.
Precisely. Imagine you have an elderly patient, chronic hypertensive. His resting systolic is, say, 170, if he drops to 100 on induction.
He's technically normotensive by the textbook definition.
But his brain and his kidneys are panicking. He has lost nearly 40% of his perfusion pressure. That is profound hypotension for him.
Okay, so I need to show that I understand that context.
Yes. So the model answer is, Sir, hypotension is defined absolutely as a systolic blood pressure less than 90 mmHg, or mean arterial pressure less than 60 mmHg, but then you immediately qualify it. However, it is also defined relative to the patient as a decrease of more than 20 to 30% from their baseline blood pressure.
Got it. So absolute numbers first. SBP less than 90, MAP less than 60. Then the relative caveat, the 20 to 30% drop, which shows I'm a thinking doctor, not just a robot reciting numbers.
Exactly. Now we move to physiology. This is the very high yield section. If you get the physiology right, the pharmacology is just logic. If you get this wrong, you're just guessing with dangerous drugs.
Yeah.
Everything, and I mean everything, comes back to one equation.
The holy grail. Mean arterial pressure equals cardiac output times systemic vascular resistance plus right atrial pressure.
Correct. Now look at that equation. It tells you that your blood pressure is essentially the product of flow, which is cardiac output, and resistance, which is SVR.
It's basically Ohm's law, isn't it? Voltage equals current times resistance.
It is exactly that. We are just electricians for the cardiovascular system. Now, in practice, we usually ignore the right atrial pressure part. It's a small number, relatively speaking. So you are left with two giant levers, the pump, your CO, and the pipes, your SVR. If the pressure is down, one of those two things is broken. It's that simple.
Okay, let's break down the pump then. Cardiac output is heart rate times stroke volume. Heart rate is pretty straightforward. But stroke volume, that's where all the nuance is.
Right, and stroke volume itself is determined by three things. What are they?
Preload, contractility, and afterload.
Good. Let's drill down on preload. Most residents just say, it's volume.
But it's not just volume, is it? It's about the stretch on the muscle fibers.
It is tension. It's the end diastolic wall stress. It's the Frank Starling mechanism. Think of a slingshot.
The further I pull the band back, the farther the stone flies.
Up to a point. If you pull it back too far, the band snaps.
Yeah.
That's heart failure. But yes, generally, more stretch equals a better squeeze. That is why fluids work. You're stretching those myocardial fibers to optimize their overlap. Now, what about afterload?
That's the resistance the heart has to push against to get the blood out.
And this is governed by Laplace's law. This is a favorite Viva question. Wall stress equals pressure times radius, divided by 2 times wall thickness. Why do we care about this formula?
Because it explains why a dilated, failing heart is so inefficient.
Exactly. Look at the numerator, radius. If the heart is dilated, that radius is large, and the wall stress, the work the heart has to do, it just skyrockets. This is why a cornerstone of heart failure treatment is reducing afterload. We're trying to lower that wall stress so the heart doesn't burn itself out.
Okay, that makes perfect sense. And then we have the pipes, the systemic vascular resistance, or SVR.
This is primarily arterial or tone. This is the thumb over the garden hose, You increase the resistance, the pressure backs up, and it has to rise. And this is controlled by the autonomic nervous system.
Specifically the sympathetic tone, from T1 to L2.
Yes, that and the baroreceptor reflex. Why is this so relevant to us as anesthetists?
Because anesthesia interferes with it. Volatile anesthetics, they depress the baroreceptor reflex. So normally, if your BP drops, your heart rate should spike to compensate. But on induction with, say, sevoflurane, that reflex is blunted.
Correct. And what about spinal anesthesia?
A spinal just knocks out the sympathetic outflow entirely. You lose the thumb on the hose, the vessels just dilate, and the pressure crashes.
Okay, so we have the definition and the mechanics. Now, the examiner asks you to classify hypotension. I feel like there are a dozen ways to do this. How do you give a clean, structured answer?
Stick to the standard framework, the 4 main categories of shock.
Good. Go for it.
Right. 1. Hypovolemic. The tank is empty. Hemorrhage dehydration. The core problem is low preload. 2. Cardiogenic. The pump is broken. An MI, valvular disease, cardiomyopathy. 3. Distributive. The pipes are too wide. Sepsis, anaphylaxis, neurogenic shock. The problem is low SVR. And 4. Obstructive. Something is physically blocking the flow. Cardiac tamponade, attention pneumothorax, a massive PE.
Perfect. Now, where do we fit our most common anesthesia scenarios into that framework? Let's start with a spinal.
Well, spinal and epidural anesthesia are classic distributive shock. It's a chemical sympathectomy. But there's often a relative hypovolemic component too, because all that blood pools in the dilated veins, the capacitance vessels, so it's not available to return to the heart.
Correct. And general anesthesia induction?
That's usually a mix. You get vasodilation from propofol, that's distributive, and you also get direct myocardial depression from the volatile agents. That's a cardiogenic component.
Good. You framed the problem. The physiology is clear. Now, the examiner says, "Doctor, the BP is 70/40. What do you do? Be careful. Do not jump to drugs yet."
Right. Safety first. I start with initial assessment and non-pharmacological management. A and B before C. Check the airway, make sure they're getting 100% oxygen, then ensure my IV is working, monitors are cycling frequently.
Good. Then what?
Fluids. You have to think about restoring preload first. But there's a Viva trap here I need to avoid. The idea of preloading with fluids before a spinal, it isn't very effective, is it? The kidneys just pee it out. Co-loading, giving the fluids while the block is setting in, that works much better.
Spot on. Preloading is out. Co-loading is in. What about positioning?
The Trendelenburg position, head down, legs up. The idea is to auto-transfuse about, 300 to 500 milliliters of blood from the legs back to the central circulation.
Is head down always the right answer, though?
No, definitely not. If the patient has raised intracranial pressure or is a full stomach high aspiration risk, Trendelenburg can be disastrous. In those cases, maybe just passive leg raising is a safer bet to get that auto-transfusion effect without the risks.
Good thinking. You stabilize the airway, you're running fluids, the patient is positioned, the pressure is still soft. It's time for the overview of vasoactive drugs. This is where you score the big marks. How do you classify them for the examiner?
I'd break them down by their primary hemodynamic effect. First, you have vasopressors. They squeeze the vessels, they increase SVR. Then, inotropes. They kick the heart. They increase contractility. And finally, inodilators. They do a bit of both. They increase contractility, but they also dilate the vessels.
Okay, and what are we trying to achieve with these drugs? What's the goal?
Well, the target is usually a MAP greater than 65 millimilli Hg, but really we want end organ perfusion. I mean, we want to see good urine output, a clear mental status if they're awake, and lactate clearance. Treating a number on a screen isn't enough.
Correct. Never forget that. We treat patients, not monitors. Now let's talk agents. Start with the pure vasopressors. Tell me about phenylephrine.
Phenylephrine is a direct alpha-1 agonist. Pure vasoconstriction. Its main hemodynamic effect is a big increase in SVR, which drives up the blood pressure. The downside is that it causes a reflex bradycardia. The baroreceptors see the high pressure and signal the vagus nerve to slow the heart rate down. And its main indication, it's the absolute go-to for spinal-induced hypotension.
Why? Why is it the go-to for spinals?
Because in a spinal, the primary physiological problem is vasodilation. Low SVR phenylephrine fixes that exact deficit without causing unwanted tachycardia.
And its main limitation, when would you be cautious?
It increases afterload. So if the heart is already weak, say, a patient with severe cardiomyopathy, increasing the resistance it has to pump against can actually cause the cardiac output to fall. You're essentially asking a very weak heart to push against a closed door.
Exactly. Never forget that. Phenylephrine increases afterload. Now, what about vasopressin?
Vasopressin is different. It works on V1 receptors in the vascular smooth muscle. It doesn't use adrenergic receptors at all. The key exam point here is that it works well in acidic environments where catecholamines like norepinephrine start to fail. This makes it a great rescue drug for refractory shock. In the ICU, it's often used as a sparing agent in septic shock to lower the norepinephrine dose.
Good. Now let's move to the heavy hitters, the mixed vasopressors. Start with the gold standard.
Norepinephrine. Its mechanism is a potent alpha-1 agonist effect, but with a modest beta-1 kick as well. Clinically, it's the drug of choice for septic shock, and the reason is that it powerfully squeezes the vessels with its alpha effect to raise MAP, but the beta-1 effect helps maintain some cardiac output, and it does so without the crazy tachycardia you might see with other drugs.
Okay, so compare that to epinephrine.
Epinephrine is sort of the kitchen sink drug. It's a potent agonist at both alpha and beta receptors, and it's dose-dependent. At low doses, you get mostly beta effects inotropy and chronotropy. At high doses, the alpha vasoconstriction really dominates, so its indications are the really dire situations: cardiac arrest, severe anaphylaxis, profound cardiogenic shock.
And the downside?
Well, it causes massive tachycardia, which can lead to arrhythmias, and it also raises lactate levels through a direct metabolic effect, which can sometimes confuse the clinical picture in sepsis.
Okay, very good. Let's move to inotropes. Let's talk about dopamine.
Dopamine. This is full of Viva traps. The mechanism is famously dose-dependent. Low dose is dopaminergic, medium dose is beta, and high dose is alpha. The biggest trap, of course, is the renal dose myth. For years, everyone thought low-dose dopamine protected the kidneys. The evidence is clear now. It doesn't. It might increase urine output, but it does not protect renal function or improve patient outcomes. Modern guidelines basically say to skip it and go straight to norepinephrine for septic shock.
Correct. If you say renal dose dopamine in the exam, you might just fail on the spot. It's that outdated. So what about dobutamine?
Dobutamine is a much cleaner drug. It's predominantly a beta-1 agonist. Its main use is for pure pump failure, cardiogenic shock, where the primary problem is a weak heart, but it has a major limitation. It has some beta-2 activity, which means it causes vasodilation. If you give dobutamine to a patient who is hypovolemic, an empty tank, their blood pressure will just crash. You have to make sure they are volume replete first.
Excellent. Now, we arrive at the specific agent mentioned in the question. Inodilators, specifically Levosimendan, this is an exam favorite because it's physiologically elegant. It solves a problem that older drugs like dobutamine couldn't. Walk me through it.
Okay, so the problem with a traditional inotrope like dobutamine or epinephrine is that they're biologically expensive.
Expensive is the perfect word. Explain that. How does a traditional inotrope work?
It stimulates the beta-1 receptor, which causes a cascade that floods the myocardial cell with calcium. And calcium is the fuel for contractions, so more calcium means a stronger squeeze.
Right. But what's the cost of that?
The cost is that the cell has to burn a massive amount of energy, of ATP, to pump all that excess calcium back out again, so your myocardial oxygen consumption goes through the roof.
It's like whipping a starving horse. You might get a short burst of speed, but you're killing the animal in the long run. Plus, all that extra intracellular calcium makes the cell irritable. It leads to arrhythmias.
And this is where Levosimendan comes in. It's called a calcium sensitizer.
Right. And Levosimendan is smart. It doesn't flood the cell with more calcium. Instead, it binds directly to troponin C, which is the molecular switch that triggers contraction, and it makes that switch more sensitive to the calcium that is already present in the cell.
So it's not adding more fuel, it's just making the engine more efficient with the fuel it has.
Precisely. It stabilizes the on position of that troponin C switch. You get a more forceful contraction without raising intracellular calcium levels.
Which means you don't have that huge energy cost of pumping the calcium out later.
Inotropy without the oxygen penalty. That is the phrase that gets you the gold medal in the exam. It improves myocardial efficiency. But wait, there's a second mechanism. It's not just an inotrope.
It's an inodilator. It also causes vasodilation. It opens potassium channels, right?
Specifically, the ATP-sensitive potassium channels in the vascular smooth muscle. When these channels open, potassium leaves the cell hypopolarizes, and the muscle relaxes.
So you get vasodilation.
You get the perfect hemodynamic profile for heart failure. You increase contractility through the first mechanism while simultaneously lowering both SVR and preload through the second mechanism. You strengthen the pump and you open up the pipes for it.
Which makes it ideal for decompensated heart failure, cardiogenic shock, or those low cardiac output states you see after cardiac surgery.
And what about its pharmacokinetics? This is also unique.
It has active metabolites that have a very long half-life. They can last for days. So a single 24-hour infusion can provide hemodynamic support for up to a week.
Excellent. That's a 20-mark answer right there. Just briefly, before we move on, where does ephedrine fit in?
Ephedrine is an indirect sympathomimetic. It works by causing the release of stored norepinephrine from the nerve terminals. Its niche is really spinal hypotension, especially when there's an associated bradycardia, because it has both alpha and beta effects. The big limitation is tachyphylaxis. Once you deplete the stores of norepinephrine, it just stops working.
Okay, we have the toolkit. Now, for part D of your answer, cause-specific management, this is where you show you can be a clinician. Scenario 1. Hypotension during spinal anesthesia. Talk me through it.
Okay. The pathophysiology is sympathectomy. Venodilation causes blood to pool. Arteriolar dilation drops the SVR. And if the block is high, like above T4, you block the cardioaccelerator fibers and you get bradycardia.
So what's your algorithm?
First, I check the heart rate. If the patient is bradycardic, I use ephedrine. It will fix both the blood pressure and the heart rate. If the patient is tachycardic or even has a normal heart rate, I use phenylephrine. It will fix the BP and the reflex will help bring the heart rate down. But if there's severe bradycardia or asystole, you don't hesitate. You give epinephrine.
Good. And what about the Bizel-Jarisch reflex?
Yeah, that's the paradox where a severely underfilled ventricle can trigger a profound, vaguely mediated bradycardia. You treat that with volume and an agent like ephedrine or epinephrine.
Okay. Scenario 2. Septic shock.
The goal is a MAP over 65. The physiology is classic distributive shock, massive vasodilation. The drug of choice is norepinephrine. First line, no question. If it's refractory, you can add vasopressin as a second agent or consider corticosteroids.
Scenario 3. Cardiogenic shock.
Here the problem is the pump. It's weak. SVR is usually high as a compensatory mechanism, which just makes it even harder for that failing heart to eject blood. So you do not want to use a pure vasoconstrictor, like phenylephrine. You'll crush the heart. You need inotropes, Dobutamine or Levosimendan to improve the squeeze. You might need a little bit of norepinephrine to maintain a survivable MAP, but the focus has to be on improving contractility.
And finally, scenario 4. Hypovolemic shock.
Rule number 1, fluids or blood first, always. Giving vasopressors to an empty tank is it's malpractice. The number on the monitor might look a little better as you clamp down the vessels, but you're causing profound tissue ischemia because there's still no flow.
Good. You mentioned monitoring briefly earlier.
Yeah.
What are your key endpoints when you're titrating these drugs?
Well, you need an invasive arterial line for any unstable patient. You need that beat-to-beat resolution. But the BP is just a number. The real goal is monitoring end organ perfusion. So I'm looking at urine output, aiming for more than 0.5 milliliters per kilo per hour. I'm looking at lactate clearance. Is the acidosis resolving? And if the patient is awake, what's their mental status?
And complications. What happens if you get too aggressive with these agents?
The big ones are arrhythmias, especially with the beta agonists like epinephrine or dopamine. Then there's ischemia. You can cause myocardial ischemia from the increased oxygen demand of tachycardia, or you can cause peripheral ischemia, gut ischemia, gangrenous fingers and toes, from excessive vasoconstriction, and of course, extravasation. If these drugs leak out of a peripheral IV, they cause severe tissue necrosis. That's why a central line is strongly preferred.
All right, we're in the home stretch now. I'm going to throw 3 Viva traps at you. These are the classic situations where the standard algorithm will kill the patient. Trap 1, you have hypotension in a patient with severe aortic stenosis. What do you do?
Ooh, okay, that's dangerous. The physiology here is a fixed cardiac output. The aortic valve is just a pinhole. These patients are completely dependent on their SVR to maintain perfusion pressure. If you vasodilate them, like with the spinal, they can arrest. So the management is to maintain SVR at all costs. Phenylephrine is your friend here. And you must avoid tachycardia because they need that diastolic time to perfuse their thickened heart muscle.
Very good. Trap 2. The patient on chronic ACE inhibitors who becomes profoundly hypotensive on induction.
That's vasoplegic syndrome. Their whole renin-angiotensin system is blocked. Standard drugs like ephedrine might not work well because their catecholamine stores might be depleted or the receptors are downregulated. The answer here is often vasopressin because it works on a completely different receptor pathway that isn't blocked.
Excellent. And the third and most common trap.
The student who just jumps straight to drugs without thinking? The answer is to always say, I will first assess and optimize the patient's volume status. Don't be the doctor who starts a norepinephrine infusion on a dehydrated patient.
Perfect. Now, the final flourish. You have 2 minutes left in your exam. You need to draw a diagram or present a summary structure on the paper. What do you put down?
Okay, visually I do three things. First, I draw the shock box. A simple 2x2 table classifying shock based on high or low cardiac output and high or low SVR. It instantly shows you understand the underlying hemodynamics. Second, a receptor table, just a quick comparison of alpha versus beta activity for norepi, epi, dobutamine, etc. And third, a simple spinal hypotension algorithm, a flow chart showing heart rate low, use ephedrine, heart rate high or normal, use phenylephrine.
And your closing statement, give me the model conclusion paragraph.
In conclusion, hypotension is a symptom, not a disease. Successful management requires rapid identification of the underlying phenotype. Is this a preload, a pump, or an afterload problem? Treatment must then be tailored. Fluids for the empty tank, a pure vasopressor like phenylephrine for the dilated tank, and inotropes for the weak pump. And in complex cases like decompensated heart failure, advanced agents like Levosimendan offer the unique advantage of improving contractility without the significant oxygen penalty of traditional catecholamines.
Outstanding. You've passed.
Phew, thank you. That was intense.
It needs to be. In the exam, and more importantly in the operating room, you don't get a second chance to get the physiology right.
So for everyone listening, grab a piece of paper right now. I'm serious. Draw that receptor table. Write down the equation MAP equals CO times SVR. Just lock it into your memory.
And remember, this deep dive was based on core texts like Miller, Morgan, Harrison's. Go to the source. Read the chapters.
Thanks for listening to this deep dive. Good luck with your exams and go save some lives.
See you next time.